And then, all right, so before again we get started, I just want to make a few announcements about things that we have coming up at LSI. So coming up, we have a big event at Loyola University called Enhancing Lupus by Empowering the Lupus Community on October 29th. This is a luncheon and symposium, so we do encourage all of you to sign up and join us. This will be a great day of learning and connecting with the lupus community, plus a free lunch. On November 10th, we have a presentation on lupus and fibromyalgia presented by Dr. Kat Smalls. That will be at 6:30 at night. That is another webinar similar to tonight's presentation. And then on December 3rd, we have our Rush Educational Clinic and LSI event. This is an annual event that we do at Rush. So this is at the hospital. More information and registration can be found at our website at www.lupusil.org. So be sure to check that out and register. All these events are free to attend, but we do need the registration so we can provide you the link like we did for tonight's presentation. About tonight's presentation, this event is for educational informational purposes only and serve to benefit our mission. The Lupus Society of Illinois does not provide medical advice or recommendations. This information should not be substitute or replace expert medical care. Before making changes to your medical care, consult a qualified healthcare professional familiar with your medical condition and healthcare status. Again, this event will be recorded and will archive on the Lupus Society of Illinois' website. Tonight's presentation is by Dr. Ben Smalls. Dr. Ben Smalls is a rheumatologist in Chicago, Illinois. He's received his BA from Brown University and his MD from Rush Medical College. He completed a fellowship in rheumatology at the University of Illinois. He now practices at Rheumatology Associates in private rheumatology practice group in Chicago. Dr. Smalls specializes in diagnosing and treating patients with all forms of arthritis and rheumatic.
And she says she brings a huge.
Excuse me, can you please mute? Thank you. Sorry, where was I on that? Patients and the latest and most effective treatments available. He is also interested in research and has published several journal articles, abstracts, and book chapters. Dr. Smalls is a board certified in both internal medicine and rheumatology. He is a member of a medical staff at Northwestern Memorial Hospital and has an office at both Rush and Northwestern. You can reach Dr. Smalls at 312-226-8228 for more information or to schedule an appointment. I'm going to turn it over to Dr. Smalls right now. Okay.
Okay. Hi, I'm Dr. Ben Small. I'm a rheumatologist, and I'll be talking about lupus, anxiety, and depression. Okay. Okay, so lupus is a chronic autoimmune disease of unknown cause that can affect virtually any organ of the body. Immunologic abnormalities, like the production of anti-nuclear antibodies, ANA, are a prominent feature in the disease. Patients present with varying clinical features from mild joint and skin involvement to life-threatening kidney, hematologic, and central nervous system involvement. The diagnosis of lupus is generally based on both clinical and laboratory findings after excluding alternative diagnoses. In the absence of lupus criteria, or diagnostic criteria, lupus classification criteria are often used by doctors to guide and make the diagnosis. And serologic findings such as double-stranded DNA and anti-Smith antibodies are also highly associated with this disease. So constitutional symptoms like fatigue, fever, weight loss are present in most patients with lupus. And fatigue is the most common, over 80% of patients have it. It can be associated with depression, sleep problems, and fibromyalgia. Fever is seen in about 50% of patients. Muscle pain is also very common, as well as weight changes. Weight loss can be due sometimes to medications like hydroxychloroquine, and weight gain, especially due to taking steroids like prednisone, and salt and water retention, increased appetite, those things. So arthritis and arthralgias are also very common. Over 90% of patients with lupus have them. And you can get an arthritis with actual inflammation in 65 to 70% of patients. And it can be, in multiple joints, it can be symmetrical, it can be painful. Usually does not cause erosions or joint destruction, but it can cause an erosive arthritis like rheumatoid arthritis. And this is just a picture of the arthritis that you can get in lupus and the x-ray as well. So mucocutaneous involvement, that's involvement of the skin and mucous membranes, is also common. The most common rash is the malar rash or butterfly rash that you get over the cheeks and the nose. And it can be a flat or raised red rash, usually after sun exposure. Some patients get discoid lesions, which can be can cause scarring, like you see in that picture. And then photosensitivity is common, just sensitivity to sun and sunlight. And that can worsen the skin lesions in a lot of patients with lupus. You can have mouth or nasal sores or ulcers, and you can get alopecia, which is hair loss. That can be non-scarring, but it can also be scarring, especially in patients with discoid lupus. You can get a lot of, you can get cardiac involvement as well in lupus. The pericardium, which is the outer layer of the heart, the myocardium in the middle or the muscle layer, as well as the valves, the conduction system, and the coronary arteries, the arteries of the heart. Pericarditis is the most common, and it's about 25% of patients. You can get these Liebman sacs endocarditis, which you get these little vegetations, which you can see here on the heart valves. And then myocarditis is uncommon, but it can be severe, and that's, inflammation of the muscle of the heart. And then lupus patients have an increased risk of coronary artery disease. And then there's neonatal lupus, which occurs in babies of women with lupus who have SSA and SSB antibodies, and that can cause congenital heart block. So vascular manifestations, you can have Raynaud phenomenon, which is induced by the cold in about 50% of patients, and you can get white, blue, or even red fingertips, like you can see the fingertips in these pictures. And then there's vasculitis, which is inflammation of the blood vessels, which you can get in lupus, and it can involve all vessels. Small vessels is the most common, with cutaneous lesions, skin lesions. And then thromboembolic disease is you can have blood clots, especially if you have antiphospholipid antibodies, and that can affect both veins and arteries. So kidney involvement is also very common. It's in about 50% of patients with lupus. So you need to screen for lupus nephritis with things like urinalysis, measuring the amount of protein in the urine, and the glomerular filtration rate, which is a measure of kidney function. Those things are important in managing lupus patients. You can get different types of glomerulonephritis. So oftentimes you need a kidney biopsy to sort of define the type and extent of the kidney involvement. And then lupus nephritis can be variable in presentation. You can have asymptomatic blood in the urine, you can have protein in the urine, you can have nephrotic syndrome, which is a lot of protein in the urine, and then rapidly progressive glomerulonephritis with loss of kidney function. There can be GI involvement, up to 40% of patients, and it can involve any organ kind of in the GI system. So the esophagus, the intestines, the liver, the pancreas, the vessels in the abdomen, as well as the lining of the abdomen. So there can be inflammation all over the GI tract. And there's also pulmonary involvement, so lung involvement is also common. Pleuritis, which is inflammation of the pleura, which is sort of the lining of the lungs. So you can get fluid in the lungs. And then things like pneumonitis, interstitial lung disease, pulmonary hypertension, shrinking lung syndrome, and alveolar hemorrhage. And you have to distinguish patients with respiratory symptoms. You want to make sure they don't have infections because a lot of them are on immunosuppressive therapy. And also the risk of thromboembolic involvement or blood clots is also there with antiphospholipid antibodies or lupus anticoagulant. And then blood or hematologic abnormalities are common in all three types of blood cells. So white blood cells, red blood cells, and platelets can be involved. So anemia is low red blood cells or hemoglobin. That's common. It's usually anemia of chronic disease or anemia of inflammation. But you can also have autoimmune hemolytic anemia, which is rare, but it can be severe and require immediate therapy. Leukopenia, which is low white blood cells, is also common in about 50% of patients. And that can be due to lymphopenia, which is low lymphocytes, or neutropenia, which is low neutrophils. And the neutropenia can come from toxicity from different immunosuppressive medicines. And then there's thrombocytopenia, low platelets, and that that's common as well. Rarely you can get severe thrombocytopenia that requires treatment. So you can also have ophthalmologic or eye involvement. Keratoconjunctivitis sicca, which is dry eyes, is the most common manifestation, and that's can be a result of secondary Sjogren's syndrome. The next most common is retinal vasculopathy and cotton wool spots. You can also get optic neuropathy, choroidopathy, episcleritis, scleritis, and anterior uveitis as well. So there's neurologic and neuropsychiatric involvement, and that kind of consists of a broad range of different manifestations, including stroke, seizures, cognitive dysfunction, delirium, psychosis, depression, and peripheral neuropathies. And other less common things like movement disorders, cranial neuropathies, myelitis, and meningitis can be seen. You can also have thromboembolic events, especially with antiphospholipid antibodies or lupus anticoagulant. And that's only in about 20% of patients. And then arterial thromboemboli can cause neurologic problems and things like stroke or seizures, and they can cause cognitive defects as well. So this is just kind of a general overview of kind of all the different clinical manifestations that you can get in lupus. So you can get fever, depression, fatigue, weight loss, and then, it involves kind of the whole body, the eyes, the skin, the chest, the vessels, the joints, heart, abdomen, nervous system, the kidneys, the muscles, and the blood. And you see joints are the most common, and followed by skin and blood abnormalities. And so lab testing, you need to do a CBC, which is a complete blood count with looking for things like leukopenia, anemia, and thrombocytopenia. Looking at kidney function, so elevated creatinine can be suggestive of kidney problems or kidney dysfunction. Urinalysis, looking for blood, white blood cells, protein, or cellular cast in the urine, and then protein electrophoresis can show hypergammaglobulinemia, which can suggest a systemic inflammatory process. So continuing with lab testing, so antiphospholipid antibodies, that's lupus anticoagulant, both IgG and IgM, anticardiolipin antibodies, and beta-2 glycoprotein antibodies as well, C3 and C4 complement levels, SED rate, ESR, and C-reactive protein CRP levels, which are markers of inflammation, and then a urine protein to creatinine ratio. And then the lupus specific antibodies, which are the anti-dsDNA and anti-Smith antibodies. And those are seen in 70 for double-stranded DNA and 30% for Smith antibodies in patients with lupus. A lot of patients have SSA and or SSB antibodies, 30 and 20% of patients. And these are, most commonly associated with Sjogren's syndrome. You can also have RNP antibodies, which is something we see in mixed connective tissue disease. And then these anti-ribosomal P antibodies are specific for lupus as well. And so the diagnosis of lupus is usually based on kind of the judgment of the clinician. And then, often it's challenging because there's so much variability in lupus. It can be very mild and it can be much more severe. So there's all these different classification criteria, which really were designed for research purposes. So people could be in research studies, but we use them a lot for diagnosing lupus as well, because it kind of helps to, break down how many of the different criteria patients have and to see if they meet the criteria that way. So there's 3 different types of criteria from 97, from 2012, and from 2019. The original criteria was you just needed 4 of 11 criteria. That's the 97 criteria. The SLIC criteria, which is 4 of 17 criteria, they basically took those 11 and added 6 more immunologic criteria to it. So you need 4 of 17 in that criteria. And then the newest one, the EULAR ACR criteria, you need a positive ANA and you have to score 10 or more points. And we'll look at that a little more closely. So this is the kind of original mnemonic that we all learned in medical school, SOAP, BRAIN, MD. And that's the 11 different criteria, and you need to have 4 of the 11 to meet the criteria. And so as you can see, so S is for serositis, O oral ulcers, A arthritis, P photosensitivity, and BRAIN is blood, renal, ANA, immunologic, and neurologic, and then the MD is malar rash and discoid rash. So the 2012 criteria is, has the original 11 clinical criteria that we just talked about, and then these immunologic criteria, and you still need 4 criteria, but one of them has to be in this immunologic category. And then the new EULAR ACR criteria, you need to have a total of 10 points, and you can see different things are assigned different amounts of points. So double-stranded DNA and Smith both already give you 6 points. C3 and C4 being low is 4 points. Arthritis gives you 6 points. And then class 3 or 4 lupus nephritis, you already get all 10 points just for that. So that satisfies the criteria just in and of itself. So this is just kind of an overview of the 3 different criteria: ACR, which is 4 of 11, the SLIC, which is 4 of 17, and then the EULAR ACR, which is ANA positive, and then you have to have 10 points. So just a quick overview of lupus medications: nonsteroidal anti-inflammatories, NSAIDs, and then after that, you would go to anti-malarial drugs like hydroxychloroquine, then corticosteroids like prednisone, and immunosuppressants like azathioprine, mycophenolate, methotrexate, cyclosporin, and voclosporin, which is a new medicine, lupus. Then there's the biologics: belimumab, Benlysta, rituximab, Rituxan, and nifrolumab, which is Safnello. And then there's depression. So now we'll talk a little bit about depression. So it's a mood disorder that causes feelings of sadness and loss of interest. It's also called major depressive disorder or clinical depression, and affects how you feel, think, and behave. Can lead to a variety of emotional and physical problems. So you may have trouble doing your normal day-to-day activities. Sometimes you might feel like life isn't worth living. Most people with depression feel better with medication, psychotherapy, or both. So this is just kind of an overview by the numbers. So the median age is 32 when depression is diagnosed. 35% of patients, or 35% of adults who don't receive treatment with depression. It's 17.7 million. That's the annual number of Americans who experience depression. 50%. You have a 50% chance of having a second episode of depression, and it's the number one cause of disability in the U.S. And then, so the symptoms of depression: poor concentration, suicidal thoughts, loss of joy and pleasure, fatigue, withdrawal from family, irritability, lack of motivation, headaches, muscle aches, upset stomach, weight gain, weight loss, and difficulty sleeping. And this is just kind of a more thorough overview of the symptoms, but you can see a lot of these symptoms that you have in depression are also seen in lupus. So it can be hard sometimes to know what's lupus, what's depression, or, do you have both? So you can have sadness, irritability, sleep problems, fatigue, weight loss or weight gain, anxiety, difficulty concentrating. You can have back pain, headaches, and obviously suicidal thoughts. And then, so the diagnosis is based on physical exam, lab testing, psychiatric evaluation, usually filling out a questionnaire, and then the DSM-5, which is a kind of diagnostic manual for classifying criteria for different psychiatric disorders. So this is the questionnaire, the PHQ-9, which is a 9-item patient health questionnaire. And see, there's 9 different questions, and you can answer from 0, not at all, to 3, which is nearly every day. And then you add up the total, of all the 9 questions. Based on the total score, 1 to 4 is minimal, 10 to 14 is moderate, and then 20 to 27 is severe depression. And so there's many different types of depression: major depressive disorder, major depression or clinical depression, which is when you have these symptoms which last, which are intense or overwhelming, and can last they last longer than 2 weeks, and they interfere with everyday life. But there's also bipolar depression, where you have alternating periods between low and high moods or manic periods. There's perinatal and postpartum depression. There's persistent depressive disorder, which is also called dysthymia, and that's kind of less severe than major depression, but it can be longer lasting for 2 years or more. And there's premenstrual dysphoric disorder, which affects women around the menstrual period. And there's psychotic depression, and then there's seasonal affective disorder or seasonal depression. So what causes depression? There's lots of things that go into it. Brain chemistry, you can have abnormalities in brain chemical levels. You can genetics are involved. So if you have a relative with depression, you may be more likely to be depressed. Life events, stress, death of loved ones, trauma, things like that can cause depression. Medical conditions, physical pain, illnesses, and then a lot of times people with chronic conditions like diabetes, cancer, heart disease, arthritis, and lupus can get depression. Medications can cause depression as a side effect. Drugs and alcohol can cause depression or make it worse. And then personality, like people who are easily overwhelmed or have trouble coping may be more prone to depression. So how is depression treated? So self-help is important, getting regular exercise, getting enough sleep, spending time with people you care about and who care about you, counseling, psychotherapy, talking and having therapy is a good thing. People use different, complementary therapies, things like massage, acupuncture, hypnosis, biofeedback, medications. Obviously, we use like antidepressants can be helpful. They can help change the brain chemistry that causes depression. They can take a few weeks to have an effect, and they can also have side effects. Then there's things like brain stimulation therapy, which is things like ECT, electroconvulsive therapy, transcranial magnetic stimulation, TMS, and vagus nerve stimulation. So in terms of medications, most commonly used are the SSRI, selective serotonin reuptake inhibitors. And these are, usually well tolerated and safer than some other medicines. So we use them a lot. And a lot of these SSRIs are common, like Celexa, Lexapro, Prozac, Paxil, and Zoloft. And then we also use SNRIs, those are serotonin norepinephrine reuptake inhibitors, such as duloxetine or Cymbalta, Effexor, and others. Then there's atypical antidepressants, things like Wellbutrin and mirtazapine and trazodone that we sometimes use. And then there's the tricyclic antidepressants, which are things like amitriptyline, which can be effective, but they also have more side effects, so we don't use them quite as much for depression these days. And there's the monoamine oxidase inhibitors, which also have usually more side effects, so they're not used as much anymore. And then we use a lot of other types of medications as well, like anti-anxiety medicines, stimulant medicines for patients with depression as well. But psychotherapy is important and very helpful, I think, too. Talk therapy or psychological therapy. There's different kinds of psychotherapy, such as cognitive behavioral therapy or interpersonal therapy. And this psychotherapy can be good. It can help you adjust to a crisis, and sort of ways to replace negative beliefs and help and develop positive interactions, find better ways to cope and solve problems, identify the issues that lead to your depression and change your behaviors, and then help you sort of relieve or ease the depression symptoms, make you feel less hopeless or less angry. It can help you set realistic goals, and then you can develop ability to sort of tolerate and accept distress in healthier ways. So electroconvulsive therapy is these electrical currents pass through your brain, and it helps impact the function and effect of the neurotransmitters in your brain, which helps to relieve depression. And it's usually used for people with severe depression, who haven't responded to other types of treatment or at very high risk for suicide. And there's transcranial magnetic stimulation, TMS, for people who haven't responded to antidepressants. And a coil is placed on the scalp, and it sends magnetic impulses, which stimulates the cells in your brain, and it helps, regulate mood and depression. So this is just a little diagram of the ECT. They have these electrodes sending electricity, to the brain, and it also monitors your heart rate and blood pressure, oxygen level, your muscle activity. So the next thing we'll talk about is anxiety. And anxiety is a normal reaction to stress and can be beneficial in some situations. It can alert us to dangers, help us prepare and pay attention. But anxiety disorders differ from normal feelings of nervousness and anxiousness. because you have excessive fear and anxiety, and they can be, detrimental, and they can hold you back in a lot of ways. So anxiety disorders are most common. They're actually the most common mental disorders, and they affect nearly 60% of adults at some point in their lives. So signs of anxiety: frequent worry, withdrawal from social life, fixation or fear of the next panic attack, irrational fear, avoidance of harmless objects, places, or situations, out of the blue panic attacks, and then things like recurring nightmares, flashbacks, or numbing of past trauma. So how common are anxiety disorders? In any year, the estimated percent in the US adults for various different anxiety disorders are for specific phobias, 8 to 12%, social anxiety disorder, 7%, panic disorder, 2 to 3%, agoraphobia, 1 to 2.9%, generalized anxiety disorder, 2%, separation anxiety disorder, 0.9 to 1.9%. Then women are more likely than men to experience anxiety disorders. So to help diagnose anxiety disorders, similar to depression, you have to do a physical exam just to make sure, that anxiety isn't linked to medications or underlying medical conditions. You have to do blood and urine tests, to rule out medical conditions, and if there's any other concurrent medical conditions suspected. You have to do an interview, medical history, and you also use questionnaires like in depression, and then you have to satisfy the DSM-5 criteria. So the questionnaire that is commonly used, the GAD-7, which is 7 questions as opposed to the 9 questions for depression, but it's similarly scored 0 to 3, and then you total all 7 questions, and then if your score is 0 to 4, it's usually none or minimal anxiety. But if you have between 15 and 21, that's considered severe anxiety. So the treatment for anxiety: psychotherapy, talk therapy, psychological counseling, and you work with a therapist to reduce your anxiety symptoms. Cognitive behavioral therapy is the most effective, especially for generalized anxiety disorder. Usually short-term treatment, cognitive behavioral therapy, focusing on giving you the skills to manage your worries and help you return to your activities that you've avoided because of the anxiety. And then medications are also used to treat anxiety. And the medications, similar to depression, the antidepressants are used a lot, like SSRIs and SNRIs. Usually these are the first line medications. There's also anti-anxiety medicine like buspirone, which can be used, and it can be used with antidepressants. But it like antidepressants, it can take up to several weeks to have an effect. And then benzodiazepines you can use in limited circumstances for relief of anxiety symptoms. But these are only used for a short time usually because they can be habit forming, and they're definitely not good for people who have problems with alcohol or drug abuse. So chronic illness and depression. So an estimated 1/3 of people with serious life-changing chronic illness or disease will experience symptoms of depression. So after diagnosis of a serious illness, feelings of sadness and despair are normal. So why is depression common in people who have chronic illness? So depression is one of the most common complications. People who have chronic illnesses, they have to adjust to their illness and to the treatment. And it can affect a person's mobility, independence. It can change the way they live, the way they see themselves, and the way they relate to others. And these can be stressful, and they can cause, a lot of despair and sadness. And then sometimes having a chronic illness can trigger depression. So the doctor has to decide whether these are symptoms of depression or just a normal reaction to the stress of having a chronic medical condition. But usually if they're so intense or debilitating that they might require treatment like an antidepressant. So lupus, anxiety, and depression has been reported. It's been reported that there are 2 times higher likelihood or higher prevalence of depression in lupus patients compared to the general population. Previous studies reported that anxiety disorders were twice as prevalent among lupus patients compared to controls. So depression and anxiety are often have profound impacts on lupus patients in terms of health, well-being, increasing cardiovascular disease, heart attacks, suicide, physical disability, decreased quality of life, and the higher risk of premature mortality. So therefore, depression and anxiety may be useful targets for intervention aimed at improving health and quality of life in patients with lupus. Lupus patients are at a high risk for depression and anxiety, as we said. In one meta-analysis, people with the prevalence of major depression in lupus was 24% and anxiety was 37%. So this study was by Zhang in Psychiatry, BMC Psychiatry 2017. It looked at a total of 59 different studies with over 10,000 patients. And it found that, as we said, the major depression was 24% and anxiety was 37%. So there's a high prevalence in lupus patients. And this, shows that rheumatologists should screen for depression and anxiety in their patients and refer them to mental health providers to find strategies to prevent and treat depression and anxiety in their patients. Another study by Mustafa in Seminars in Arthritis and Rheumatism in 2020 looked at people with depression and anxiety in lupus, and this study found the prevalence of depression was 35% and the prevalence of anxiety was over 25%. So another study found depression and anxiety in patients with lupus 45 and 37%. So these are real high. So again, these show that depression and anxiety are very common in lupus patients. And also these showed that there were higher levels of anxiety and a younger age. So high anxiety and younger age may increase the risk for depression. So even more depression in people with a lot of anxiety and at a younger age. So basically the conclusions of this study were that lupus can affect multiple organs, including the central nervous system, including the brain. It can cause several neuropsychiatric syndromes, including depression and anxiety. So the burden of lupus with depression, and having lupus and depression may increase the risk of suicide. And then it also found that mood disorder in these patients, especially in depression, comes from several causes, including, pathology in the brain itself, and then the psychological reaction to the disease. So depression in other chronic diseases, there's a higher rate of depression in, other chronic medical illnesses, such as systemic sclerosis, showed 1 year and lifetime prevalence 11% and 23%. And then these rates are twice that of the general population. And then, looking at depression in cancer patients could be up to as high as 30%. And it's associated with, having more depression is associated with more severe physical pain. And this is just kind of an overview of, lots of different studies. And on the right, you can see the percent of patients with depression. So you can see these studies: 44%, 65%, 47%, 41%. So, a lot of these studies, 30 and 40% and up sometimes for depression. So the pathogenesis of depression in lupus. So there's 2 theories. One is that it's due to psychological factors, due to the stress of being diagnosed with a chronic disease at a young age. And it could also be due to, the organ damage taking place in the brain. And then this damage is thought to be most likely due to the immune system or be immune mediated. So there's these things called pro-inflammatory cytokines, which are released. TNF alpha is a big one, but IL-1, IL-1 beta, IL-6, IL-8, they play an important role in the development of depression. There's the blood-brain barrier, which can get disrupted, and that's the barrier between the blood and the brain. And then when this barrier gets disrupted, these autoantibodies can gain access to inside, to the brain. And then, studies have shown, or it's been reported that central blood flow reduction, so lack of blood flow in the brain, can also be associated with, different cytokines and autoantibodies, which can lead to depression. So depression can also be caused by steroids, which we use to treat depression. So a lot of patients on steroids can have depression. And then other things, there's other factors like stress, medicine, light, and viruses and things like that that play a role. Hereditary predisposition also plays a role. So you're more likely to develop depression in lupus if someone in your family has it. And then I guess the main theory, I think, is that it's multifactorial. Most people think it's a complex interaction between cytokines, antibodies, genetic factors, and environmental factors. So this is just a diagram of showing this BBB, blood-brain barrier. If that gets disrupted, then these antibodies can get in. And then sometimes environmental stress, things like infection, they can further disrupt that barrier. And then the infections can cause the immune system to become activated. And that, causes all these cytokines to be released. And those, combined with these different antibodies that can cross the blood-brain barrier, plus, the vessel problems that you can get in lupus, and all that can kind of combine to cause injury to the brain, like we see in this diagram. And then this is just kind of another diagram of showing all the different things, these pro-inflammatory, which cause inflammation, cytokines, autoantibodies, hereditary predisposition, environmental factors, and then the iatrogenic, like medications. They can all cause disruption of the blood-brain barrier, and then antibodies can get in. This can cause autoimmune damage, and then that leads to depression. This is just a cycle, diagram of the cycle where you can see that if you've got a lot of stress, that can cause depression, that can cause you to be not very compliant with your medicine, that can cause your disease to flare, and that can lead to a worsening quality of life, which in turn causes more stress and more depression and worse compliance, and the circle could kind of keep perpetuating. So I think it's important, that all these decreasing stress, decreasing depression, complying with your medicine, keeping the disease under control, all affect quality of life, and that helps control your disease much better. So the management of depression in lupus, it kind of depends on if this is clinical depression versus the normal depression that you can get with chronic disease, and it's also making sure you're treating the psychological causes as well as the organic disease causes. So using medicines like steroids, immunosuppressants, and antidepressants in combination to help treat the lupus as well as treating the depression. And if you're treating them together, that's the best way to keep everything under control. One study showed combining Celebrex, which is an anti-inflammatory, pain medicine, and fluoxetine, which is an antidepressant. It showed that these patients had greater antidepressant effect than just the antidepressant alone. So using an anti-inflammatory helped the depression in combination with an antidepressant. So EULAR, so that's the European League, they recommended treatment of depression, lupus, with a combination, like we talked about, so steroids, immunosuppressants, and antidepressants. So this is just talking about study medication adherence. So a study in the Journal of Clinical Rheumatology looked at medication adherence and depression, and it found that low adherence, like low, complying or regularly taking your treatment. It was a lot of patients, didn't have very good compliance with or adherence to the medication. And it led to poor outcomes in people with lupus. So this study basically found that depression was a strong correlate for low medication adherence. So if you have a lot of depression, you're less likely to take your medicine, in the proper way or take it regularly. So, so mental health interventions aiming to address and treat depression, I think, will really help with patients, adhering to their medication and taking it properly, which is very important. And then just a quick diagram, the 5 stages of grief: denial, anger, bargain, depression, and acceptance. This is sort of the classic 5-stage model, but this is the modified 7-stage model, 7 stages of grief for chronic disease. So denial, pleading, bargaining, desperation, then anger, then anxiety and depression, then loss of self and confusion, then reevaluation of life, roles and goals, and then finally acceptance. And acceptance is the point, we hope that all the patients can get to. So I think the best treatment advice is to find a good rheumatologist to manage your lupus, and to find a good psychiatrist or therapist to manage your depression or anxiety, or depression and anxiety. And then you have to take care of your mind and your body. So things that can be very helpful: yoga, tai chi, massage, Pilates, acupuncture, meditation, regular exercise, getting good sleep, usually about 7 to 8 hours of sleep, uninterrupted sleep, and then having a healthy, balanced diet is important too. And kind of all these things to take care of your mind and your body. So if you or someone you know has thoughts of hurting themselves, please call the National Suicide Prevention Lifeline at 800-273-8255. This is a national network of local crisis centers and provides free, private emotional support to people in suicidal crisis or emotional distress 24 hours a day, 7 days a week. And yeah, here's my references. And that is it. Thank you very much.
So thank you, first of all, so much, Dr. Small, for your presentation. It was really good information. Very different than we've had before. So I think everyone, it definitely is learning a lot. If anyone has any questions, there's a chat box at the bottom of the screen. You can chat a question over to everyone, and I will be able to read those over to Dr. Small. But there is one question already. It said, this is from someone unknown, so I don't know who wrote this, but your body goes through crazy, obviously, when in a lupus flare causes from stressing. In today's world, it's hard to not worry stress with everything going on. Besides medication, how can one try to relax and not stress?
Yeah, well, I think a lot of these things that I mentioned at the end are good, like yoga, tai chi, massage, acupuncture, meditation. I think, and doing things you enjoy, and taking time to kind of do stuff for yourself, and whatever that is. But I think getting good sleep is really important too, to keep you relaxed, to keep your pain better, and, to help with fatigue and other symptoms. And then I think, diet is important too, just, having a healthy, balanced diet and all. I think it's a combination of all those things, and kind of trying to relax your mind and treat your body at the same time. And relaxing your mind, I think, will help with your physical symptoms.
All right, Mari wrote a question, and what's the difference between depression and anxiety?
Okay, well, I mean, they're different the diagnostic criteria are different. So you would have to meet certain number of criteria from, a questionnaire, for example. So if you weren't sure with a patient, you might give them both questionnaires and see how they scored. But depression is more, you don't have, you feel kind of down and depressed. You don't have a lot of hope. You feel like maybe life is worthless, those kind of symptoms. Whereas anxiety is more, your fear, you have like sort of irrational fears of things, afraid to, different phobias, perhaps going out, speaking, meeting new people, doing new things, just kind of worrying excessively about, health and other things. There's so many different anxieties you can have, but a lot of times they coexist. So people have depression and anxiety a lot of times. So sometimes it's hard, and a lot of the symptoms are similar. So you would need, someone, who's experienced, a psychiatrist or someone who has a lot of experience with depression, anxiety to make that diagnosis. But sometimes it can be more clear cut, and other times it's harder to differentiate.
Okay, will depression make any of the lupus issues worse?
Yeah, it will. Like we talked about a couple things, like when you have more depression, you tend to not be as good and following through with your taking your medications regularly and kind of doing a lot of the things that you need to do, like exercise, sleeping, eating, and you just kind of don't have the motivation to stay on top of keeping up with your treatment, and that will worsen your lupus. So sometimes depression can worsen, the physical part of lupus because you're not doing the other things to take care of yourself. So yeah, so treating depression is going to help treat your lupus in a way, because you're going to be more compliant. You're going to take more, ownership, and you're going to, take better care of yourself.
Right. Karen asked the question, I seem to be more easily angry and agitated, sometimes taking it out on my spouse. Any advice?
Well, that's a tough one. But yeah, if you're feeling angry or agitated, that could be a sign both of depression or anxiety. So you could, try to see, a doctor, therapist, or someone to see, do you have depression or anxiety? And then that could be treated, and that could, help with the, moodiness. But there could be other things, you could be, other things can affect that, not just depression, anxiety, or lupus, but it could be a combination of all those things, really. So yeah, get checked out, see your doctor and see if, there's any treatment you could get that might help with that. But I think if you're sleeping well, you're exercising, you're eating well, you're taking your medication the right way, and your disease is under good control, overall you should feel better, and typically you have less, irritability and those other symptoms that come along with depression.
Okay, we did have a request, if you could re-show the slides on stages of grief, especially the second
Yeah.
one. You could
Sure.
pull that up.
Okay, let's see. Yeah.
Okay.
this was the first one. Second one.
Are painful muscle knots, lumps in muscle tissue a common symptom of lupus or not related to lupus?
It's not a common symptom of lupus, but it could, I mean, you could have painful lumps or muscle knots. I mean, muscle pain, like muscle cramps, muscle pain is common in lupus. It doesn't typically cause knots, but if you're having muscle spasm, possibly you could have that. But that's, it'd be hard. I'd have to see, how it looked. But, you could try things like massage, heat, things like that. Sometimes muscle relaxers if you have really tight, tense muscles. But yeah, it's not a common thing, but it is something that you could see with lupus, I think.
Can you repeat what you said about Celebrex?
Yeah, it was. There were a study showed looked at treating patients with Celebrex, which is an anti-inflammatory, a non-steroidal anti-inflammatory pain medicine, and fluoxetine, which is an antidepressant. And they found that the people that were on Celebrex in combination with fluoxetine had greater antidepressant effect, or less depression essentially, than people who were just on the antidepressant. So even though Celebrex is an anti-inflammatory pain medicine, it seemed to help with depression when combined with an antidepressant. So I think that just shows that treating pain is going to help with depression, because if you're not, uncomfortable, if you're not in pain, you're not going to be as, unhappy, as miserable as you would be if you were in pain. So that was kind of an interesting finding, I think, but yeah.
And then I'm not sure how to pronounce this, but it said that you mentioned this a few times.
Cytokine. Yeah.
Okay, that is. There's a few questions on this that popped up. So if you could kind of explain that more, and
Right.
the cause with anxiety in lupus patients, or is this a therapy specific to depression?
No, I mean, cytokines are in kind of all autoimmune diseases, like rheumatoid arthritis, but also in lupus. So pro-inflammatory cytokines are ones that create more inflammation. So these cytokines are involved, they think, in lupus, affecting the blood-brain barrier, which is kind of the barrier between your blood and your brain. So keeps things out of your brain. If that barrier gets disrupted, which these inflammatory cytokines like TNF alpha can do, that could cause potentially damage to the brain, which is something that, we see in patients with depression. There could be a disruption of the brain itself. So we showed this, this diagram showing kind of, these are these cytokines. Here it says IL-6 and IL-8. Those are two of them, that they can disrupt this blood-brain barrier, and that can let these antibodies in that could cause, damage to the brain, and potentially could lead to more symptoms of depression, among other things. But that's kind of the theory behind them. But the the cytokines can cause an inflammation and damage to your joints, to all parts of your body. But we were sort of looking at just how it affects the brain in lupus. And lupus patients get problems with, memory and seizures and strokes and lots of problems.
You got in the shower, get out. Okay. I want
beyond
to
just
call
depression.
your mom before the night is over, okay?
Um, please, phones if you can.
What is that?
Your phone.
You want to try it?
I'm sorry. Um,
Okay.
And then I know we just have a couple minutes left. There's a couple of questions still coming in. One thing that we're asking is do you recommend as a rheumatologist, like a therapist or a psychiatrist? Like, do people come to you, or should that work if you are feeling anxiety or depression?
Yeah, I mean, you could, I mean, most commonly it would be your primary care doctor, like, you know, your internist, who would refer you to, you know, a psychiatrist or a therapist. But we sometimes will recommend a patient see, you know, the rheumatologist can sometimes do that as well. But typically it's the primary care doctor who would refer you out to a specialist, like a psychiatrist or a psychotherapist.
All right, so Veronica wrote a question. Her rheumatologist cut off her Plaquenil because I had to see a cardio for prolonged QT that was resolved. But I have had horrible muscle joint pain and fatigue. I see a psychiatrist, and because my depression has been triggered with these symptoms, she doubled my Zoloft. My question is, would me having stopped the Plaquenil cause these symptoms?
It could. Yeah, that's sometimes one problem with Plaquenil is that prolonged QT, because it can sometimes cause that or worsen that. So we oftentimes, you know, patients will get an EKG to look for that. And if they do have a prolonged QT, then usually you would choose a different medicine than Plaquenil to treat. If it was temporary and it wasn't, you know, then that resolved and you had an EKG test that showed a normal QT, maybe you could, you know, go back on the Plaquenil. But there's also other medicines you could take in place of Plaquenil that might, you know, help with your symptoms for lupus, you know, methotrexate or others. So that's a possibility also.
Okay, yeah, she just asked, can you recommend the others? So I think you just mentioned that probably while she was typing.
Yeah, yeah. I mean, it would azathioprine is one, methotrexate is one, you know, mycophenolate is one, you know, and then there's, you know, obviously steroids or, you know, the biologic medicines, which are the most powerful, like Benlysta. But, you know, that would depend on how severe the symptoms were and everything. But all those medicines could help with, you know, with your symptoms if you can't take hydroxychloroquine.
Okay, so I know it's like 7:30 right now. Well, one more question just popped in.
Okay.
Why is Plaquenil the go-to drug for lupus? Is that the one with the best results?
Yeah, I mean, it is kind of the medicine that everyone with lupus is on, whether you have mild lupus or severe lupus. It's usually the drug you have first. And then on top of that, if you need stronger therapy, you would take a second medicine or, you know, a different medicine on top of it. But it's because it's been shown, I mean, it helps with so many things, skin, joints, you know, it's been shown to decrease the risk of, you know, blood clots, and it kind of protects you from getting damage to your kidneys and kind of all your organs. So it's a good medicine to be on if you can, you know, as a first medicine, you know, just in the background of whatever treatment you need. And then, you know, if you need stronger medicines to add on top of that, you can. But pretty much everyone who's got lupus is on Plaquenil, unless there's a reason why they can't be on it, you know, if they have damage to their eyes or heart or something like that. But most, you know, the vast majority of our patients are on hydroxychloroquine because it's such a good medicine for lupus.
All right, well, our time is up. I know some more questions did pop up. Would I be able to email those to you, Dr. Small, for a response?
Sure.
Okay.
Yeah.
If anyone has questions that we didn't get to, I'm really sorry. Please email me at lisa@lupusil.org and I will get those over to Dr. Small and we'll get those answered for you. Again, I want to thank Dr. Small for his presentation tonight. Very good information. So thank you so much. And I want to again thank everyone who hopped on and took the time this evening to join us. I also want to thank our sponsors for this event. This event was brought on by GSK, Aurinia, and Horizon. So we thank them for allowing us to host free events like this for all of you. On behalf of the Lupus Society of Illinois, we just thank everyone. And again, we do have 3 other educational events coming up the rest of this year. So please hop onto our website at lupusil.org to check those out, register. So I hope to see you all soon. So thank you again, everyone. Have a great night.
Thanks for having me.
Thank you.
Okay, good night.
Night, everyone.